Welcome back to Diabetic Foot Files. Today we're going to talk about uncontrolled vasculitis, which is one of those sneaky limb-threatening conditions that masquerade as just another ulcer, but we're going to break it down. So, what is vasculitis? Vasculitis is inflammation because if it has an itis at the end, that means inflammation, but inflammation of the blood vessels. And that would result in vessel wall swelling, narrowing, clotting, rupture, and also tissue ischemia would be pretty much the end result. And when uncontrolled, it becomes rapidly progressive, organ damaging, limb threatening, and life threatening. So think of it as the immune system turning your vascular tree into a battlefield. And we already know how important vascular is. So, how does vasculitis form, the pathophysiology? And by the way, like I said, for medical education, this is just a brief summary. This isn't as in depth as a vascular surgeon would go into it or a pathophysiologist. But there are two major mechanisms of the pathophysiology in vasculitis. So, first one is immune complex deposition. So, the antibody and the antigen complexes deposit into the vessel wall, and that causes a complement activation. And the neutrophils are release an enzyme, and that causes a vessel damage. And then second mechanism is the ANCA mediated autoimmunity. So the antibodies attack the neutrophils. And remember, we need the neutrophils to help attack the bad things, right? And the neutrophils attack the vessel lining. So that would result in vessel wall thickening, luminal narrowing. So luminal is the inside of the vessel, clots, aneurysms, and tissue necrosis. So there are types of vasculitis, and this is just by vessel size. And like I said, we're just going to go through a very brief summary of it. But large vessel vasculitis, or I think about, we're just going general terms, Takasaru ar- arteriitis, and that's usually in young women that are their age is less than 40. And the key signs for that is weak pulses, a blood pressure difference in the arms. Then there's giant cell arteritis, not arthritis, arteritis. So inflammation of the artery, right? And those are in women who are well, older than 50, and they have to be over than 50, right? And the key signs are headaches, jaw claudication, and vision loss. Next, there's medium vessel vasculitis. Medium vessel vasculitis, their conditions are one is called polyarteritis nodosa, PAN, and the hallmark of that is renal and GI ischemia. And the second one is called Kawasaki. Okay? I'll just spell that. Kawasaki. Kawasaki. Saki, Kawasaki disease. And that happens in kids and causes also coronary aneurysms. Those are the hallmarks of it. So when it comes to vasculitis versus non-vasculitis, you can pretty much make a Venn diagram. So vasculitis, you have dermal small vessel vasculitis. You also have deep dermal subcutaneous muscular vessel vasculitis, and then they could also present with palpable purpura, hemorrhagic blisters, nodular erythema, livido racemoma, racemosa, and subcutaneous nodules. There's a lot of interesting wording. And then the next one, non-vasculitis, they would present with extravascular granuloma or granulomatosis inflammation mixed with eosinophilic infiltrate. And non-vasculitis also would present with papules like blisters, erythema, multiforme like lesions, u- uterica like lesions, angioedema like lesions, papulonodular crusted lesions, and infiltrated or swollen erythema. And conditions like this would be granulomatosis with polyangiitis, and the key organs that are affected would be the lungs and the kidneys. Next is microscopic polyangiitis, and that the key organs that are affected is the kidneys. Then there is eosinophilic granulomatosis, and the key organs that are affected or symptom that would probably happen is asthma and neuropathy. And then there's leukocytoclastic vasculitis. Key organs or key presentations you'll see with that one is skin ulcers and purpura. I have seen the leukocytoclastic vasculitis. So, how does uncontrolled vasculitis present? So, general symptoms would be fever, fatigue, weight loss, night sweats. Skin findings, which are huge when it comes to podiatry, is the palpable purpura, painful ulcers, necrotic toes, libido reticularis, and then limb-threatening signs would be sudden ischemic toes, non-healing wounds despite good pulses, neuropathy without diabetes, severe rest pain, and organ involvement. It'd be kidneys, and that would present with like blood in the urine, possibly indicating kidney failure. Then lungs, what could happen with that? If it affects the lungs, coughing up blood. If it affects the nerves, you could possibly get foot drop. And then GI, you can have abdominal pain. So, what are some of the diagnostic tests? So, you would test the ESR-CRP, which why do we test that? Because they're inflammatory markers. And remember, it causes inflammation because it's causing the neutrophils to like release these enzymes, right? Next test would be a ANCA antibody, and that would detect the autoimmune vasculitis. Next, you could possibly test, most likely should test RF or ANA to rule out lupus or rheumatoid factor, right? Another test, it would be complement levels. So that would tell you about the immune complex activity. Next test you can do is a urinalysis, which will give us the extent or if there is any kidney damage. Gold standard would be a biopsy of the skin or the kidney. And then sometimes another diagnostic test, imaging wise, would be a CT angiography. And that would most likely be able to see large vessel or medium vessel disease. So, who are prone to vasculitis? Patients who have autoimmune, rheumatoid arthritic patients, lupus patients, chronic infections like Hep C, Hep B. Certain drugs can actually cause it. Asthma patients usually have the eosinophilic type. And then older patients, they usually present with the giant cell arteriitis. So, how common is vasculitis? It's actually quite rare. So, to have the ANCA associated type vasculitis, it's usually 10 to 20 per million per year, okay? So it's very little. And giant cell arteriitis, that's most commonly in the elderly. And the one that I said that I've seen before already, so leukocytoclastic vasculitis, that happens in the skin, that's more frequent but often misdiagnosed. So what is the treatment? This is for medical education. You go to a vascular doctor, okay, or autoimmune specialist, things like that. Treatment for uncontrolled vasculitis. So in emergency phases, they usually give the patient like methylprednisolone, high dose steroids, things like that, or immunosuppressants like cyclophosphamide, and then they possibly give you biologics, which are like different antibodies, okay, like rituximab. I know I'm not saying that right, so forgive me. Next, maintenance. They might put you on methotrexate for maintenance as immunosuppressant. They usually use that for rheumatoid arthritis as well. And there's another one called mycophenolate, things like that. And so when it comes to wound care or limb care, this is our zone, even though it doesn't really affect, because we'll see like extreme vasculitic ulcers because it's wounds. You would have to still offload regardless of that. Aggressive ischemic monitoring, that's why you need to always refer patients to vascular regardless of anything. And infection control, and then avoid an unnecessary debridement in ischemic vasculitis. ulcers. That's a huge thing. That's why you need to be able to recognize the different diagnoses because, yes, with certain diabetic ulcers, a debridement would be resetting, taking it out of its chronic phase, putting it back into the acute phase. But if the ulcer is ischemic and you're doing sharp debridement, things like that, you're going to make it worse. Okay. And that'll be unnecessary. And you're just going to make the ischemia progress more because you're causing more vascular damage. So, why does this matter for diabetic foot? So, vasculitis ulcers can look like diabetic ulcers, they can look like peripheral arterial ulcers, and they can look like pressure ulcers, but they worsen despite revascularization. You can have severe pain and have purpura around the wounds. And if you misdiagnose vasculitis and you miss it, amputation risk skyrockets. Yes. So I hope people are aware of that. And let's do some quick questions. So a 72-year-old male with a headache, jaw pain while chewing, and vision changes most likely has giant cell arteritis, okay? Because that is classic large vessel vasculitic emergency and it can actually cause blindness. So, which vasculitis is most associated with asthma and high eosinophils? It is eosinophilic granulomatosis with polyangiitis, and that includes asthma, neuropathy, and esophagia. Next, what is the gold standard for confirming vasculitis diagnosis? Is biopsy because it's the tissue that we're able to tell the actual truth. Which lab finding supports immune complex mediated vasculitis? Is going to be low complement levels. And what is the first line emergency treatment for severe systemic vasculitis? It's going to be high dose corticosteroids. Okay, next one. A child with a fever, red tongue, rash, and coronary artery aneurysm likely has Kawasaki disease. And which organ damage is most life-threatening in systemic vasculitis? It's the kidneys. And which infection can trigger vasculitis? Hepatitis B and hepatitis C. And why is unnecessary debridement dangerous in a vasculitic ulcer? Because underlying blood supply perfusion is compromised. So, in closing, not every wound is a diabetes problem, and that's why we have to keep it in mind. Sometimes it's the blood vessels themselves that are under attack, and recognizing vasculitis could mean the difference between them salvaged and them lost. And that's why I love vascular. Still get them a full vascular because they'll be able to recognize it for sure. So, when in doubt, yeah, but you should always baseline have a vascular evaluation for the patient. So this is Diabetic Footballs. I know this was quick again. Hope everybody enjoyed the Super Bowl and take care of your feet because they take care of you.